This is a lecture about electrocardiograms. An electrocardiogram is basically measuring the electricity coming out of the heart. This is why you put a lot of stickers around the heart connected to wires which measure the electricity coming out from different places from the heart. So if you put stickers on the left side of the heart, you're going to measure the left portion. If you're going to put stuff on the right, you're going to measure the right. And then on a rhythm strip, you can see and compare the two together. So just to give you some basics, this picture is really important for understanding and reading the baseline EKGs. You see, there's two different planes of leads. There's one plane of the blue that's highlighted here, AVL, AVR, lead 1, 2, 3, and AVF. And there's another orientation which points out in 3D towards you out of the screen from V1 to V6. Now, you can already see that they're in certain orientations. Most of the leads are pointing towards this way. And there's a reason for that, because the left ventricle is the most muscular part of the heart. And where you have more muscle, you have more contractility, more depolarization, and thus more electrical current, which makes sense to be more fine-tunedly measured on the left side. So again, if I'm concerned about a left heart pathology, the leads that would make sense to look at would be 1, V6, V5, V4, 2, maybe AVL. And if I'm concerned about the right heart or maybe the inferior part, definitely AVR, lead 3, V1, and so on and so forth. So just to make this and hammer this idea home, we're looking at the most hypertrophied part of the heart, which is the left ventricle. We know on the rhythm strip that the QRS complex is the ventricle depolarization. So of course, the higher the amplitude, the harder the contractility and higher the depolarization. So our eyes gravitate towards V4, V5, V6, which has the highest amplitude. And this really does make sense because V4, V5, V6 map out the left ventricle. So before you even start to interpret an EKG, you're going to be handed an EKG by a nurse or a student, and you're going to have to see, did they even do this right? So to do that, you look in two areas. First, you look and compare lead 1 and AVR. If we go back for a second, you remember lead 1 was pointing towards the left, and a lead opposite towards lead 1 is a AVR, pretty much towards the right. So whatever happens in 1, it should happen opposite in AVR, correct? So if we have an upward deflection in 1, which it makes the most sense because it's pointing towards the left where the left ventricle is, you should have a downward depolarization, downward deflection in AVR. So far so good. These are reciprocals of each other. Next, you look at the V leads. You should see the QRS complex basically increasing in amplitude as you progress to V1 to V6, mainly peaking in V4. Again, that makes sense because that's where the left heart is. V1 is a bit further, V2 closer, V3 closer, V4 closest, and so on and so forth. So this is how you check the validity of an EKG. Next, you want to understand the rate. So the rate is, of course, the number of times your heartbeats per minute. The normal amount is 60. Let me get my handy-dandy pointer over here. So the normal rate is 60 to 100. And the way you can check this very quickly is by understanding that each big box here, oops, I drew a bit bigger. Each big box here is about 0.2 milliseconds. So if you divide however many boxes apart these RR complexes are by 300, you should get the amount of beats per minute. So 300 divided by 2 is 150, divided by 3, 100. So anything lower than 60 is bradycardic. Anything higher than 100 is tachycardic. Now, looking at the rhythm is, I guess, more of an art. You have to look at the R complexes and see if they're spaced out equally apart. In this case, they're about 4 to 5 boxes apart. Each one is consistently regular. Over here, they're not, because this to this, over here and over here, they're regular, but this is much longer than the previous complexes. Similarly, this distance is not equal to this, which is not equal to this. The next thing you want to really look at is, are the P waves coming with every Q wave? Over here, you can see every P is with every Q, and every QRS complex is with every P wave. over here, you can see, okay, there's a P wave here and a Q here. However, there's a P wave here and there's no Q here. So you can already tell this is arrhythmic. The next thing you want to concern yourself with is the axis deviation of the heart. Now, we talked about the left ventricle being the thickest part of the heart. And because of this, the electrical charge, the net vector should be pointing towards the left. And this is what axis really is. If you add up all the sum of the charge, all the net vectors, where does it point? Usually it should be to the left because the left ventricle is the most depolarizing part. And this is the normal axis. However, if you have dextrocardia and your left is on the right, or you have right ventricular hypertrophy, you can see how this can become odd and give you right axis deviation. So what you want to do, the easy way, is look at lead 2. Lead 2 is very in line with the left ventricle. So if the QRS complex is upward in lead 2, you're done. This is a normal axis deviation. Now we need to talk about intervals. Now, before I do that, let's just understand what the anatomy of an EKG is. The P wave represents the atria. The ventricles are represented by this QRS complex. And the QT interval is basically from the Q to the T segment point, and this represents when the ventricles are depolarizing. And this can come in handy because a lot of drugs actually prolong this and can cause arrhythmias. So again, this is a normal length. You have a P, you have a QRS, a T wave, and it repeats P, QRS, T wave. And this is the normal length of each interval. So let's talk about PR intervals, because PR intervals actually tell us a lot about AV blocks. And this makes sense because the atria and ventricle basically communicate together, and the atria is defined by the PR interval. So the PR interval, the normal amount is less than 200 milliseconds. Now, gauging this on an EKG, if we can go back for a second, that means if this is a big box, and we talked about this being a 200 milliseconds, this segment should be lower than one big box. So already, I guess this is a bit odd. But over here, you know that PR segment should be less than one big box. So let's look at this EKG. This looks pretty normal. That's definitely less than one big box. This P wave looks about one big box, and this P wave is definitely bigger than one big box. And you can already see there's a QRS dropped after a P. So this is an arrhythmia again, particularly a Mobitz type 1. So let's talk about the different types of heart blocks. This is a nice poem that we can go over. If the R is far from the P, then you have a first degree. And this basically means that the P wave and the PR segment is very long. It's definitely more than one box. However, there are no dropped QRS complexes, and this is usually a benign finding. PR gets longer, drop. It's a case of Weckenbach. So you can see that the PR starts off normal, gets longer, gets even longer, and all of a sudden after the P, there is no QRS wave. And this is a case of Weckenbach or Mobitz type 1. And this is also still a bit benign. And this is the one we just saw before. If some R's don't get through, prepare to pace that Mobitz 2. And this is very bad because while the PR segment is less than one big box, it's relatively normal, you suddenly get a QRS complex drop. And this is very dangerous. This absolutely needs to be paced. If the R's and P's don't agree, prepare to pace that third degree. And this is basically when you have complete dissociation of the AV nodes. You see that there's a P, there's a QRS, there's a P, there's a P again, there's a P, there's a QRS. It's completely bad, and absolutely you need to pace it. Now let's talk about bundle branch blocks. And this is defined by the QRS complex. The QRS complex is, of course, the ventricles depolarizing. So just to give you what a normal QRS complex is, it should depolarize in less than 100 milliseconds, which is basically less than half a big box, which is why it's so pointy. A wide QRS complex indicates a pathology. Why is there a widening? Because there's probably a conduction velocity block somewhere called a bundle branch block. So let's talk about what happens. But before I do, let's just talk about how the septum actually depolarizes. The normal way a heart depolarizes, for all intents and purposes, we can say in the intraventricular septum. Let me just change colors here so you can see better. Let's change to blue. So it usually depolarizes on the left side of the intraventricular septum, and it goes down the ventricular septum, usually to the right first, and then to the left. But because this happens simultaneously very fast, what you get after the P wave is a very fast Q wave and QRS complex, and you only get one peak because both are masked by it. Now, with that in mind, we'll talk about what happens with bundle branch blocks, the right and the left. And the V1 and V6 leads are definitely helpful here because the left heart, we know, is usually mapped by V6. The right heart is mapped by V1. So let's try this trick again with the normal heart, and we'll walk through each of these because these can get a bit complicated. You start discharging your electrical charge on the left side of the intraventricular septum. Because you're on the left side of the intraventricular septum, your tendency is going to want to go towards the right. And if you do this, you're going to get an upward deflection in V1 because you're going towards V1. And as the charge goes towards V1, you're going to get an upward deflection. And then later on, it's going to go to towards the left ventricle to depolarize that. And you're going to go, of course, away from V1 in this case. And so you're going to get a downward deflection. And this is just the repolarization to becoming to baseline. Same thing with V6. You're discharging away from V6 in the beginning, which is why you get this downward deflection. And then you get a large upward deflection because of all this muscle over here. And then this is just returning to baseline. So let me clear this screen. Oops. Let me clear this. There we go. And let's talk about right bundle branch block. What happens in a right bundle branch block? Again, this is lead V1, this is lead V6. So in a right bundle branch block, you have problems going on in the right ventricle. So what's going to happen if you depolarize from here this time? Well, your tendency is still to go towards the right side away from the left side because you're discharging from the left side. So you get R over here, the first depolarization. But as it realizes it can't really make its way through this bundle branch block right now, it's going to end up going towards the left ventricle, and you're going to have a downward deflection in V1 because it's going away from V1. And then as it makes its way very slowly across this conduction velocity block, you're going to have an upward deflection, and this is what we call R prime. And this is just, again, returning back to normal. And looking at V6, same logic, right? You're going first away from V6 because you're going towards the right. And then you're going towards V6 first because you realize the right part is blocked. And then you eventually slowly go towards the right, towards V1, and you get a downward deflection. Now, all of this is happening. It's taking a lot of time because this is blocked. And you can already see that these QRS complexes are much wider than the normal ones. So that is right bundle branch block. Let's talk about left bundle branch block. This gets a bit complicated, but it shouldn't be. In a left bundle branch block, the left heart is sort of knocked out, right? So there's a conduction velocity block here. This also means there's a conduction velocity block on the left side of the intraventricular septum, so you're actually going to start depolarizing from the right side of the heart. If you're starting from the right side of the heart, the next charge is actually going to want to go to the left side, and this sort of reverses things, but you can still figure it out based on the leads and what they say. So starting from this point, it's going to go away from V1. Let me just, that's V1. It's going to go away from V1. That's why you get a net downward deflection. And it realizes, whoops, can't go over here because it's blocked right now. So then it goes towards V1 this time. And that's why you get an upward deflection. Now, later on, of course, it goes slowly towards V6, which is why you get a widening of the QRS complex and a downward deflection in V1 because it's going away from it, and this is just depolarizing. Just to top it all off, we'll talk about V6. Again, first, the discharge is coming from the left side, it's going to V6, so an upward deflection over here. And then you're gonna make its way, when you realize there's a block on the left side, you're gonna make your way away from V6 to V1 towards the right side, a net downward deflection away from V6. And then finally, as you make your way to across the blockage V6, which is why it's prolonged, you're gonna have an upward deflection and return to baseline. And the QT interval, there's not a lot to know about it, but basically the normal QT interval by math is less than 400 milliseconds, but what you can really do is eyeball it. Basically, an R to R complex should be more than half of what a QT is. So Q to T, you can already see that this is about half, so anything more than this would be abnormal or prolonged, and anything less should be relatively normal. Now let's talk about enlargements. Enlargements of the atrium and ventricles can show up on leads, as we talked about before, because the amplitude correlates to the conduction velocity and the rate of depolarization, and this basically means there's more muscle there because it's contracting really hard. So for instance, if the right atrium is, or any atrium for this case, is very hypertrophied, say because of COPD or some lung problem, cor pulmonale of some sort, you know that the atrium is marked by the P wave. And if the P wave is peaked to a point greater than the QRS or equivalent to the QRS, you know in your heart of hearts that the atrium is not as strong as the QRS complex. So anything like this is an abnormality. You can see that the atria is definitely enlarged here. If, for instance, we were measuring the left lead, the right atrium, we would probably look at AVR, right? Because that's what maps out to that. Potentially V1 as well. Now, looking at right ventricular hypertrophy. On our map here, the right ventricle maps out to this area, which we know lead V1 and V2 as well can be marked here. So this basically means we should expect to see a higher amplitude in V1 and V2, and that's exactly what we see here. V1 and V2 are pretty high. In fact, we can understand it in lead 1, which is pointing towards the left. It's actually having a negative deflection. Why is that? Because the right side of the heart is so hypertrophied, it's causing the net electrical charge to go towards the left. Now, in ischemia, injury, infarction, not a lot to say about here because one leads to the other, which leads to the other, and you have an MI. We know that normal looks like this. Ischemia can have ST depression. This is where you have your angina unstable or stable. Injury can have ST elevation, which progresses to infarction, which is where you get this tombstone appearance of a Q wave. So always be on the lookout for that. So the last thing we want to do is finally interpret an EKG. So I'll give you a few seconds to pause and understand this. Okay, so let's understand this EKG. Remember, the first thing we want to do is to check the validity. We want to look at lead 1 and AVR. Are they reciprocals of each other? Well, it looks like they are. This is a downward deflection, that's an upward deflection. However, we already see something wonky is going on. Usually we think that in lead 1, we should have an upward deflection, but instead we have a downward deflection here. Now, in V1 to V6, the QRS complex is progressively increasing, so that does tell me that this is a pretty valid EKG. Now let's look at the rate. Let's look at the rhythm strip in 2 because it's a nice thing over down here. So let's pick one right at the end here. So this is basically 1, 2, 3 boxes. This is 1, 2, 3 boxes. 1, 2, 3, 1, 2, 3, 1, 2, 3. Well, this is basically a good rate because remember 3 boxes, 300 divided by 3 is 100. So we know it is 100 beats per minute. And now let's look at rate. As we saw, the interval is 3 boxes between each, and it is not irregular. So it's a regularly regular rhythm. Every P wave is with a QRS, and every QRS is with a P wave. So the rhythm is regularly regular. Now, what do we want to do? Let's look at the intervals now. The interval PR interval. That's definitely less than 1 box, so the PR interval is normal. The QRS complex is definitely less than half a box, so the QRS complexes are normal. And finally, the QT interval. That is about less than half of an RR, so I would say the QT interval is also normal. Now what we want to look at is axis. Now, remember what we said? We look at lead 2. Well, there seems to be a net downward deflection in lead 2. And this was confirmed with our lead 1 being downwards and AVR being upwards. So what's actually happening right now is that it's a right axis deviation right off the bat. And this tells me that the net depolarization is going towards the right. Now this makes me suspicious of some sort of right heart pathology. And if we look at these really crazy high QRS complexes, these map out exactly to where the right ventricle would be seen. And particularly the QRS complex, not the P wave, is high. Therefore, we're thinking of the right ventricle and not the right atrium. So here we would say right ventricular hypertrophy. And we can check for any ST elevations, any ST depressions, any other tombstone appearances, and we don't see that. So the final impression of this